So good afternoon. This is Nikhil Yawalker speaking from Switzerland. It's a great pleasure to give you my experience on psoriasis and the Swiss aspect of psoriasis. This is where I'm speaking from Bern, the capital of Switzerland. These are my disclosures. Especially thankful also to Novartis for organizing this session. So, as you all know, as dermatologists, psoriasis is a multifaceted disease with a significant impact on quality of life. And as you can see on the right side, we have different flavors of psoriasis, and especially if the face, the hands, if it's a very severe form of psoriasis, then impact of quality is, of course, really impact. So, in the last 2 decades, I would say, we have made significant advances, in the immunopathogenesis of the disease, and this has led to new systemic treatments like the biologics. We have 4 generations of biologics now that started off with the TNF inhibitors, then we got ustekinumab, the IL-12/23 blocking agent, then the IL-17 inhibitors, and lately the 23p90 inhibitors. And it's like a sweetie shop, what should we choose of these? They're all very good drugs, and I'm often asked which one is the best of these treatments. So there's no simple answer to that, because psoriasis, as I mentioned before, has so many flavors, and there are so many kinds of people we are treating. So it depends, first of all, of course, on the severity of the disease, the type of disease, the locations of the disease, the impact, quality of life, which comorbidities are around, like psoriasis arthritis, for example, is very important to ask for. Then, of course, drug-related factors, like, how quickly does a drug work, how good is the maintenance of this drug, the drug survival, for example, how safe is the drug. These are all very important factors when deciding what to give to a certain patient. And last but not least, of course, the patient itself, his preference. Does he like to get injections every week, for example, like we do it for Embryo? Would he really prefer something once a month or once every 2nd or 3rd month, for example? What's his age? Is it a child or is it an adult? Is he very old? Does he have too many or a lot of comorbidities, as I mentioned before? All these factors play in when we're deciding what to give a certain patient. Now, this is recent data from Switzerland and Germany. It's data from a registry. And here we ask the patients what they really want to, what's important for them, what's really important for them. And many of them say that getting better quickly, or getting healed of all the skin defects, different regions, the psoriasis, arthritis, and all that is important for them. Now, let me illustrate that with a case here. So this is a guy, one of the first guys I actually treated with secukinumab. He had multiple therapies before that. He was on topical phototherapy, methotrexate, fumarates, also biologics. He was really flaring badly and wanted to have a quick response. At that time, we got secukinumab. I started him on secukinumab, as you can appreciate here, just in a couple of weeks, just 4 weeks, and practically a great result with a PASI going down from 42 to 4.5. Again, this is a typical feature of the IL-17 blocking agents. And as you can see here, also with ixekizumab, this was a lady, she was planning to go for exams and was really flaring because of the stress. And as you can see here, just after 2 injections, week 2, a great response. This is again substantiated in the studies, and you probably know these studies, CLEAR and CLARITY. Of course, a nice response in comparison to ustekinumab, which is a good drug too, of course, but you can see that secukinumab is superior to ustekinumab here. But what I really want to point out is the first couple of weeks, where you already see a significant difference just in a couple of weeks between secukinumab and ustekinumab here. And this is again also appreciated in a very recent study that has been performed between ixekizumab and guselkumab. So IL-17 blocking agent against IL-23 blocking agent. And again, as you can see, just by week 4, there's a significant difference, and ixekizumab works faster than the IL-23 blocking agent. So again, a typical feature of IL-17 blocking agents. If you want to have a quick fix, then you should choose IL-17 blocking agent. Now, there's a hype concerning network meta-analyses, and a lot of publications are coming out, doing this. This is a recent one showing you that the best drugs on the left-hand side, as you can see there, are the IL-17 blocking agents and the 23 blocking agents. This is the induction phase, so the first 12 to 16 weeks, and you can see the IL-17 and 23 blocking agents, so that show the best efficacy. So taken together, at least in the induction phase of the reaction of psoriasis, the big five are certainly the IL-17 blocking agents and the 23 blocking agents, especially secukinumab, ixekizumab, adalimumab, 𝐾𝐞𝐫𝐦, and risankizumab. Now, we're not treating psoriasis for just a couple of months, but we really want to see how good are the drugs in the long run. So it's the maintenance that's important. Again, I want to illustrate that with this case here. So this is a patient who's had psoriasis for over 30, 40 years, actually, long. Been suffering for a long time. He has a lot of phototherapy, a lot of methotrexate, worked a bit, but he's not really satisfied. And then, again, one of my first patients, as you can see from the years he's been treated now, and what you can see is that he's doing very well since over 4.5 years. And he's actually even reducing his dose or prolonging the intervals because it's going so well for him. So this is what some patients do by themselves. We don't usually recommend to do that, but they do it by themselves. But indeed, there's actually even a study that has recently been published, the optimized study by Reich et al. And it shows that optimally you would stay with Q4 weeks, so 4 weekly dosing. But in some patients, actually in 7.5 of 10 patients, and 74%, as you can see here, they also still maintain their response, their PASI 90 response. And you also have to see these patients that are losing the PASI 90. They're somewhere between 75 and 90. So maybe they're just getting 2 or 3 plaques more, and that's why they're losing the PASI 90 score, but they're still highly satisfied. They could still be highly satisfied, actually. So in some cases, and this is important because of the COVID discussion we're going to do in the end of this talk too, in some cases, actually, you could prolong if it's needed. But usually we would recommend to stay on the normal interval of the normal schedule for biologic therapy. Again, this is substantiated here, the long-term therapy of secukinumab showing a stable response with different ways of statistical ways of analyzing the data. And you can see the PASI 75 responses are around the 80s, the PASI 90 responses are in the 60s, and the PASI 100 responses are in between 35 and 40. So a nice response here over time. Of course, some of the patients are going to go up and down a bit, going to flare a bit because psoriasis is not a stable disease. You have different degrees of activity, maybe a stress factor around exams or some problem in your job, mobbing, or whatever, and then your psoriasis may flare, and then you may have to optimize your therapy the other way around now. So you may have to use topicals again, you may have to use excimer laser for some lesions, for example, and you can also optimize the therapy by shortening the intervals, for example. I do that in a couple of patients, and it works well. And the point I want to make here is not to change too quickly. Give the drug some time to work again, to get back to its efficacy by optimizing the therapy. Because if you're changing all the time, and this is sometimes what we see from dermatologists in practice who don't have so much experience with the biologics, then it's getting difficult for the next drug again. So bio-experienced patients are much more difficult to treat in comparison to patients that haven't received so many biologics. Again, we don't have so much data with the IL-23 blocking agents because they came up lately, but this is data with guselkumab, for example, again showing a nice response, a PASI 90 response over time. Again, in the meantime, I'm treating patients for over 2.5 years now with guselkumab, and again, I have some patients where I do have to optimize the therapy, for example, reintroduce topical steroids or even shorten the interval a year or two, instead of every 2 months to maybe 6 weeks, even 4 weeks. I usually do that for maybe 2 or 3 months just to see if if he's catching up again with the response, and then continue with the drug. So lately, we're not just looking at the PASI responses, the PASI 75, 90, and 100 responses, but we also want to get the patients down to absolute scores which are less than 3. Usually, if it's less than 3 or 2, most of the patients will be satisfied. Of course, it depends on the region, on the localization where the psoriasis is. If it's in the face, you still won't be satisfied, for example. But most of the patients are satisfied if it's below 3, as you can see here. Secukinumab leads to these low absolute PASI scores over 3 years in a very stable and nice way here. So this is as observed data. And this is feeding into the new, lot of the new guidelines. These are the French guidelines, for example, which I really like too. So it says that if you get a PASI score over 90, a PASI response over 90, or an absolute PASI below 3, then you should continue the treatment after the right. If it's between PASI 75 and PASI 90 and you still have a PASI 3, so meaning if you started off with a rather low PASI, like somewhere around 10, for example, then you should still continue treatment. If your PASI is between 75 and 90, but your absolute PASI is over 3, so on the left-hand side of the slide now, you should still consider what the patient is thinking, so what his quality of life is. If he's still satisfied, then usually the LQI will be below 4 and you can still continue. If all these don't, if you don't come up to these values, then you usually have to modify treatment. So quality of life is important, as I was mentioning before, and quality of life is especially impaired in the face, for example, hands, nails, and especially in psoriasis arthritis too, because these patients have fatigue and have pain. And this is some nice data which has recently been shown in an abstract, and it's comparing the TNF blocker with the IL-17 blocking agent. So in this case, adalimumab with secukinumab. And as you can see on the left-hand side, both are equally good concerning psoriasis arthritis. This is really nice data because the gold standard for psoriasis arthritis is usually starting off with a TNF blocker. But here, head-to-head trial showing that they're equally effective. But the nice part is, of course, the right-hand side. We have an advantage with the IL-17 blocking agents because they work better than the TNF blocking agents, as you can see here. Secukinumab significantly better than adalimumab. Again, this can be appreciated with another drug, ixekizumab, in comparison to adalimumab. Again, IL-17 blocking agent against a TNF blocking agent. Very recent data again. Here, the primary endpoint was patients who receive ACR 50 response, so a joint involvement, and a PASI 100 response, so the skin. And as you can see here again, as we saw with secukinumab before, people having both of these scores, responding to both of these scores actually, will have a better response. So 36% of the patients had this primary endpoint in comparison to 28. Again, important, if someone has psoriasis arthritis and especially severe psoriasis, we would of course recommend the rheumatologist to start off with IL-17 blocking agents if they agree. And this is nicely shown again in the recent EULAR recommendations, the European Rheumatology Board. And if you concentrate on the polyarthritis and the axial part, to the middle and the right-hand side, you can see that again, if severe psoriasis is present, the board recommends to prefer IL-17 blocking agent, for example, secukinumab. And we have a lot of data actually showing that, especially if patients have back pain, if they have an axial form of psoriasis arthritis, IL-17 blocking agents work very well here. And as you perhaps know, secukinumab has been approved for psoriasis arthritis, ankylosing spondylitis, and recently also for non-radiographic spondyloarthritis. This is a good agent. IL-17 is especially important in this axial region of psoriasis arthritis, and it's a good target for using IL-17 blocking. If it doesn't work, then the alternatives are written down there. You could even try apremilast, for example, in mild psoriasis arthritis, or you could go to a JAK inhibitor, for example. Now, There is a difference. I've been showing you randomized controlled trial data, but there is a difference between these trials and real world. Because you know, in the study population, this is a very selected population. For example, with depression, you may have here that with adalimumab, or IL-17 receptor blocking agent, this was stopped. The study was stopped because of depression and suicide there. The later studies, for example, depression was exclusion criteria. So we really want to know data from the real world, for example, because the population there has more comorbidities and it's more heterogeneous. So what about real world data regarding IL-17 blocking agents? You can see the effectiveness here of secukinumab looking at absolute PASI scores again. This is a comparison to the randomized controlled trials SCULPTURE. So 3 ኢና is a real world study which is still ongoing, and it's supposed to include around 3,000 patients. This is interim data year after 1 year, and showing that 76% of patients will have a nice, as you can see here, 76% percentage of the patients will have a PASI below, an absolute PASI below 3. So a nice response again here. Again, what I want to highlight here is that bio-naive patients will respond better than bio-experienced patients. So this is what I mentioned before. If you keep on changing the drug because you think it's not working good enough, it's going to become more and more difficult to control the patient. Of course, this also reflects high need in the patients, because these are patients who have had a lot of activity of the disease, and that's why sometimes you also have to change to the next drug. But in general, bio-naive patients work better than bio-experienced patients. Really nicely shown here. Now, what about safety in the real world? This is really an important issue that's coming up lately. And one of the important points now is, of course, the COVID pandemic, which is going around. And we have a lot of questions from dermatologists, you know, are the patients on biologics at the higher risk of contracting the disease? And if they get the disease and they have a biologics, are they going to be, is the mortality risk, for example, higher in these patients? Of course, we're recommending all our patients to stay at home, and this cartoon nicely tells you what could happen if, you know, the hospitals are overloaded. Hopefully, this is not going to happen. Just to set back a bit, as you know, the most difficult point in biologics, in giving biologics, or the most important point to keep in mind, I better say that way, are serious infections. And these are, if you look at the data, they're not often. So this is a recent publication from the US and showing that the data incidence rates per 100 patient years, and you can see that 1 to 2 patients will get a severe infection. These are usually bacterial infections. So it's pneumonia, cellulitis, for example, urinary tract infections. And what you can also appreciate in this study is that the incidence rates are a little higher if you have psoriasis arthritis. And one of the reasons are, of course, that they do a lot of combination therapy too. Sometimes people are also on systemic steroids, which enhances the risk. So keeping this data in mind, that this is particularly bacterial infection and not viral infections. Of course, viral infections are also common in patients on biologic therapies, but they're also common, you know, in the general population that are not receiving biologic therapy. Nevertheless, we do recommend that our patients, at least in Europe, get a flu vaccination before we start biologic therapy or during biologic therapy. So let me go to 2 cases and illustrate how we were handling these patients during the COVID pandemic incident. So this is a 31-year-old man with plaque psoriasis, highly impaired quality of life. Previous treatments were topicals, phototherapies, methotrexate. You know, this is a high-need patient, as you can see here, as was mentioned before. Etanercept, discontinua, with, you know, that didn't work so well, was not satisfied with the therapies. We had to change. He was also, as a comorbid patient, he also had, as you can see, he was obese. We put him on secukinumab, nice response actually. He's on since 4 years now on secukinumab, doing very well. We're highly satisfied. And his last secukinumab injection was end of February. And then the patient called me and said, so he's really anxious now, the numbers of COVID patients increased rapidly during March, the beginning of March in Switzerland was one of the highest at that time in Europe. So he was concerned if he should take the next injection after 4 weeks or not. Now, in this case, first of all, you have to ask the patient, does he have any signs of COVID? So does he have any signs of infection? How well can he do social distancing? So what's his profession, for example? Is he he was a software engineer, was working in an office with close contact to various colleagues. So what would you have recommended this patient to do? Stop secukinumab, continue secukinumab, or perhaps prolong the intervals, as I had shown you before in another patient? Before we get to the answers here, another case, 58-year-old man with psoriasis, severe psoriasis since over 30 years, previous treatment, topicals, phototherapy, methotrexate, TNF blockers, ustekinumab, secukinumab even in this case. So, and then he has a lot of comorbidities here. So metabolic syndrome, obesity, diabetes, hypertension, taking a lot of alcohol, not a risk factor. Tobacco use, very important to ask, by the way. And again, the drugs that he was taking, again, makes him a highly risk factor for mortality if he acquires COVID, for example. So ACE inhibitor, as you know, perhaps that risk. So we put him on guselkumab here, one of my first patients there. And as you can see here, he's doing quite well. We're keeping our finger crossed that he's maintaining his response. Again, he came up and gave me a call. His last guselkumab was in February, and now at the beginning of April, he was asking, should I take the next guselkumab injection or not? Should I wait? Again, no signs of COVID infection in this patient. Again, he was working in an office, a lot of people around him. So that was quite difficult. That was quite a difficult situation. Again, the questions, what would you recommend this patient to do? Stop guselkumab, continue guselkumab, or continue and prolong the intervals? Now, before we get to the answers, again, what do the guidelines say, or what do the recommendations say from the different societies? The first point we have to make, this is just since December going on. So there's no real hardcore data to say what we should do. And this is appreciated by all the societies that they say that it remains unknown to what extent COVID-19 infections impact psoriasis, and there's just limited data to say how we should handle these patients. In general, though, the attitude is that we should continue patients who are having biological therapies. This goes through many of the recommendations that are coming out. This is something I pulled out from the International League of Dermatological Societies, and they say that we don't have enough data if the patient is negative for COVID or doesn't have any signs. There's not enough evidence to justify discontinuation. So you usually continue. They would recommend to continue treatment for these biologics agents, for example. Nevertheless, they do say that you have to consider this on a case-to-case basis. You have to consider the benefits and risks, for example, especially in patients that have a lot of comorbidities like diabetes, pulmonary disease, hypertension, cardiovascular disease, kidney disease, liver disease, and malignancy. So it's an individual discussion here. Again, AAD, very similar. They say if you don't, there's not enough evidence to recommend discontinuation. So if you don't have signs of or symptoms, or if you're not positive for COVID-19, the general recommendation here would be to continue therapy. Again, they also discuss that you have to weigh the risks versus the benefits on a case-to-case basis. And what I like here, what's written here is also you have to consider tobacco use, for example, in these patients. What I also want to point out with the signs and symptoms up here is that you have to take into account not only the fever and the pulmonary signs, throat pain, but also take into account that you have loss of taste and loss of smell, which are important signs too for COVID infection. And you also have to keep in mind, if there's a patient on a TNF blocker, perhaps you won't have high temperature, high fever, because TNF is one of the cytokines that is inducing fever, inducing high temperature. And if you're blocking TNF, maybe he won't have high temperature. So when should we stop therapy? Of course, if the patient has signs, as I was mentioning before, I would certainly postpone the next injection or discontinue the therapy if he's positive. And this is going through the different societies. I think there's a general consent here that you have to stop therapy at the moment if the patient is going to be positive. Of course, this is also a point of discussion because, as you know, patients often die because of a cytokine storm. So there is a discussion that perhaps it would even be advantage to continue the immunosuppression in these patients. But at the moment, I think no one dares to really do that. And you know, in the product information too, it usually says if there is a severe infection, you should stop. So what happens if we hold therapy? And this is also, we have some data there. You know, usually the patients slowly actually relapse with many of these drugs, especially the IL-17 and 23 blocking agents. And this is nicely shown in this study here with secukinumab, where, you know, patients, even 1 of 5 patients had no relapse even after 12 years, after 1 year, and even 10% of the patients didn't have a relapse after 24 months. So usually with secukinumab, it's written down there in the corner, the median time to relapse is around 28 weeks. So we have time. We don't have to panic in these patients, even, you know, if they're doing well and we have to postpone the next dose, it's not going to be a big problem for many, many patients. Again, if we have to retreat, the next question arises, of course, are we going to do as well as in the beginning? And usually, if this is looking at the PASI 75 scores, many of them will recover in a similar fashion. Not all, it's not 100%, but you can see here that it's 93% that's going to have the same response again. And we're seeing similar data from the TNF blockers and the 23 blockers. So we don't have to panic. We have to hold the therapy. We can do that in certain circumstances. So what did I do with this patient here? He's doing very well. He's obese, but he doesn't have any other, you know, risk factors for COVID infection. We advised that he does social distancing and home office, which was possible with his employee. And in this case, because he doesn't have any other risk factors and he wanted to continue treatment too, we advised him to continue his secukinumab treatment once monthly at a regular interval. What about this guy here? This is really a difficult guy. So in the beginning, he has a lot of risk factors. He has a metabolic syndrome. He's taking drugs like ACE inhibitors. He was a heavy smoker. So we really didn't have a good feeling. And I would always say, better to be safe than sorry. So in this case here, he's doing very well. We're not expecting him to flare if we're just going to postpone for 1 month. So we postponed the therapy. The next is brekizumab injection in this guy as well. So I want to sum up. We have a lot of new drugs on the market now. The IL-17 blocking agents and the 23 blocking agents are those drugs that we usually use in most of our patients. In general, if we want to have a quick fix or if the patient has psoriasis, we would now talk to the rheumatologist, of course, but we would go for IL-17 blocking agent in many cases. With regard to COVID, better to be safe than sorry, but in many cases you can continue treatment if there are no comorbidities or risk factors. But you have to, you know, discuss this with your patient. If you have signs of infection and if the patient is positive, of course, I would postpone therapy. Thank you very much for listening. So I don't know if there are any questions I should answer. Let me go to that there. Oh, I see. Oh, I see there's a couple of questions here, so I can answer perhaps for how long should the patient be on secukinumab in general. I think this is an individual discussion with your patient. So, and many of my patients have been suffering for a long time, as you can see, and they've gone through a couple of drugs. So if it's working well with secukinumab, I don't stop therapy in these patients. And they're usually glad not to stop the therapy. But we do have some situations, some life events, for example, a pregnancy, for example, or if the patient has to have a live vaccine or an operation, a large operation, a dangerous operation, for example. In these cases, we have to stop therapy. And we do have some patients who are doing very well. For example, been on therapy for 3-4 years now, hardly had any psoriasis anymore, like a good PASI 90, nearly 100 response. Some of them may ask us, in the summer months, shouldn't we just stop and see what's going on? And in some cases, I do stop therapy if the patient wants to do that, if it's not a very active psoriasis arthritis, and see what's going on. But that's exception. Sometimes do is we prolong the intervals, just how it's going, and if he's still doing well, we continue with a prolonged interval. But in general, we would say this is a chronic disease with comorbidities, then we should continue therapy. Okay, there's another question here. How can we access a biologic according in only or other aspects should be taken into account? Yes, I think I mentioned this in this talk that, of course, the comorbidities are really important too. So it's not just the skin, but of course, you always have to ask about psoriasis arthritis, and if the patient has psoriasis arthritis, together with the rheumatologist, we will discuss which therapy should be done in that certain patient. There are different aspects of other comorbidities. If he, for example, has autoimmune disease like lupus, for example, or MS, of course, we won't give a TNF blocker in these cases, but we will go for ustekinumab, for example, or IL-17 or even 23. So we have to take a lot of aspects besides the skin into consideration. Let me see if there's another question here. Oh, I think I'm done here. Okay, thank you very much.